Okay, so Dr. Kavitha will be speaking on ectopialentis. And the discussant is Dr. Sharat Bomaj. If he's around, you can be ready as well.
ये वाला ये वाला ना
इसमें नहीं प्ले हो रहा था
ठीक है
विल टेक इट इन
ये वाला
At the outset, I thank the committee for giving me an opportunity to talk on ectopialentis. I have no financial interest in this presentation. All of us know it is the lens not being in its original place, that is the patella fossa. There are many causes. It could be congenital or associated with syndromic or metabolic causes, most common being post-trauma, and it can also be spontaneous. There are various syndromes. Marfan's homocystinuria, Will-Marchesani, and sulfite oxidase deficiency and hyperlysinemia. One clue is the way it is subluxated. We can take a clue on to the diagnosis along with the other clinical evaluation. The clinical features being pain, redness, depending on what it is, how the patient is brought in. Most common being defective vision. There could be monocular diplopia and associated amblyopia. Ectopialentis could be a total dislocation into the anterior chamber or into the vitreous, or that could be subluxation of various degrees. So you'll have to examine for the aphakic portion and the phakic portion whether you really want to conservatively treat these children or you want to take these children for surgery. The other factor which gives a clue is whether the lens is cataractous as well. And other features are associated secondary glaucoma features, as you can see in the picture on the right side above, is the ciliary staphylomas which is there. And this lens which is totally dislocated into the anterior chamber. We also need to keep in mind the predisposing factors for retinal detachment in these syndromes. Yet another factor is the systemic evaluation, which is very important in all patients without history of trauma. Cardiac evaluation and in my personal experience evaluating for homocysteine. So these children are likely to get thromboembolic phenomenon during general anesthesia, which we have seen. So spectacle correction, as I said, through the phakic or aphakic portion, I would prefer if the child is getting good vision, just defer surgery. Laser PI can be done associated with shallow AC and good vision and no symptoms. Mydriatic if the lens is dislocated anteriorly. Depending on the zonules, how much it is weakened, we can think of CTR, Sioni ring, and IMED segments, and also capsular retractors, and then think of, along with anterior vitrectomy, we can think of scleral fixated or iris fixated. But in case the eyes are having microcornea and microophthalmos with shallow AC and posterior dislocation, better the vitreoretinal surgeon takes over. There are two options. One is the iris fixated and scleral fixated. Both has plus and minus points. I prefer the iris fixated, although initially I started with scleral fixated, which takes much more time. Role of femtosecond laser is very useful when you see my video here. Depends on the degree of subluxation. Definitely, femtosecond helps in creating predictable and centered capsulotomy, which helps in successful placement of PCIOL. So I'll just run the video for 4 minutes now. This is like more than 180-degree subluxation. The zonules are so weak. Especially so if the eyes are myopic, the zonules can be weak. But otherwise, you could, one can really achieve a good rhexis here. I'm completing the rhexis. This is followed by a general hydrodissection. I just infuse in all quadrants. And I aspirate using the same cannula, or you can use the viscoelastic cannula, which is 23 gauge. The capsule can be easily removed, but in some situation, the capsule is quite tough. Probably you could use the vitrectomy cutter to remove the capsule. This is followed by a good anterior vitrectomy using 2 side ports. I have closed the main tunnel with a X suture. and just turning the cutter and do a small PI at 12 o'clock. In some situations, you can have a bleed there. Here I didn't have. This is another situation where the lens is totally into the anterior chamber. I did SICS. I'm just removing that. Now coming to the iris fixated lens to be implanted, do make two side ports 180 degrees apart. Don't make it like a tunnel, just make a stab incision. This enables us to easily achieve a proper enclavation of the claw haptics. I use heel-on so that the chamber is tight. And the other thing is, initially I used to do it as a primary procedure, but later I realized that because you would have done vitrectomy and the eye would be soft, I prefer to do it as a secondary procedure. So I get a good round pupil post-operatively. So I use a straightened dialer to enclave. Here the clue is just lift the lens slightly above. That is, you can see the haptic below the surface of iris. And then you get a clue that the haptic is there, and then you just give a tuck. I use heel-on here at this step. So you have intraoperative round pupil. Sometimes, because nowadays it is 12 mm overall length, we are getting slightly oval pupil. This is a case where the haptic is got disenclaved after few years. So there's nothing to worry about it, just go back and then enclave it. But in case if it is disenclaved and it is behind, then it is better to refer to the vitreoretinal surgeon. They will put a port and then lift it from behind and tuck it. You can see the PI as well. This is a situation where there's secondary glaucoma with ciliary staphloma. I did using a side port. I removed the lens. I didn't place an IOL here because the first criteria was to remove the lens which was causing glaucoma.